Okay, well, it's a real pleasure
Yeah.
to participate in this video conference. We all are being affected by COVID. I think it's important that we share our experiences and learn from each other, in addition to the literature, because we are all in this together and all have things to learn that are new on a daily basis. As someone said, we are flying the plane while we are building it.
We will try to define who are these vulnerable pediatric populations. So how would you define a vulnerable child?
So this has been difficult, and many organizations have been trying to define for their population who is at risk and who is not. Most of us will agree that immune suppressed children are at increased risk. It seems particularly for those who have suppression of their innate or T cell immunity, but it is not entirely clear, but it is hypothesized that it is those groups that would have the most problems, especially since the cytokine storm seems to be along the process of innate immunity, which is when the disease becomes very rapid and aggressive.
So just to summarize again for our hostess, different specialties, medical specialties define somewhat differently what is a vulnerable child.
I'll just
want to give her a minute or two so that she can catch up. And that immunosuppression, either innate immunity or T cell based immunity, immunosuppression seems to be that makes a child vulnerable to this infection. And then the question is, can you maybe give clinical conditions that you have in mind for immunosuppression?
Yes, so I will give you a very practical example. A child followed in our rheumatologic service who's on immune suppression, and I believe that means they're on biologics, actually required admission and mechanical ventilation in the intensive care unit.
You think that this child had immunosuppression because of the use of a biologic drug?
Yes.
Okay.
And I would say similarly for those children who have undergone chemotherapy for malignancies as well.
For hematologic disorders.
Or other cancers.
Or other cancers, okay. Okay. What about something closer to home, respiratory?
So the vast majority of children with asthma, we feel, do not appear to be at increased risk for having severe disease. There are about 10% of children with asthma that we would classify as severe and at risk. And when we talk about should we continue to shelter these children or should we allow them to go back to school, we are being very cautious about that. And currently we are not going to allow them to go back to school for right now. By September, they probably will be going back to school.
This is a very important information. If you wouldn't mind maybe repeating this in shorter beats, because there are many kids with asthma in Kazakhstan, and so that our hosts will transmit this knowledge very clearly.
Most children with asthma are not at increased risk for having worse disease should they catch the virus. There is a small group, about 10% of children with asthma, who we do feel are at risk. It is this population that we feel for now should not return to school.
I will just ask Garim to confirm that she got this message clearly. These children, these 10% of vulnerable children with asthma, the Canadian respirologists recommend not to go to school until September. The next group is
cystic fibrosis, and I understand that there is not many children with cystic fibrosis
in Kazakhstan.
Mm-hmm. Here again, many of these children should be able to go to school, but we have made some recommendations of those who are at risk, such as those children who are less than 2 years of age, those who have low lung function under 60%, or have had a large drop in their lung function in the last year, those who are frequently hospitalized, and those with diabetes.
It's very interesting that you mentioned diabetes, although this is diabetes that is associated with cystic fibrosis. I'm just explaining this to our translation, because there are several questions coming in on our live comments about diabetes.
And we will talk about diabetes very shortly on the list there.
Okay, very good.
So let's because there are some important things to point out. For children with bronchopulmonary dysplasia, we're recommending that those who should stay home are those who are under 2 years of age, those who are in hospital a lot, those who don't tolerate viral infections so that they often end up having to come to the hospital. And for older children who are older prematures and old enough to do lung function, if they have significant disease, again with lung function less than 60%, we would recommend that they stay home as well.
So it seems to me that several of these recommendations revolve around a pulmonary function test being less than 60%.
Yes.
Second, it's the age, less than 2 years. And third is whether or not they had some decline in health in the preceding year, you said, right? And that applies to both cystic fibrosis and bronchopulmonary dysplasia.
And I would say also to primary ciliary dyskinesia as well.
So if they're old enough, the question is, if they're old enough to do PFT, if they're not old enough to do PFT, what should you do if PFT is not feasible to do in a child?
Then you have to base it on their symptomatology, their tolerance for getting a viral infection. If every viral infection results in them having to come to the emergency room, they should avoid.
Okay, so meaning that in a child that is old enough and cooperative enough to be able to do a pulmonary function test, your primary criterion would be less than 60%. But if a child cannot do it, then you would base your recommendation whether or not to go to school on the previous history, whether or not this child had viral-induced disease or emergency visit or hospitalization. And but you also listed children in need for oxygen, which do not belong to any of these groups. Who would be these children?
So sometimes they're children with upper airway obstruction. They might have, let's say, trisomy 21, Pierre-Robin syndrome or sequence.
Genetic disease.
Genetic diseases or other congenital malformations that requires them to be on oxygen or ventilatory support. That could be non-invasive ventilatory support like CPAP or BiPAP, or it could also be meaning invasive ventilation, let's say through a tracheostomy. The one group that we do not feel is at increased risk is those who require CPAP for obstructive sleep apnea without any underlying comorbidities.
So, and again, I will summarize this for Aygerim. The children in need for oxygen or ventilatory support, I can switch here, so she will have easier time. These children do not belong to these four groups. These children would be those with, for example, malformation, genetic disease, who would need oxygen or non-invasive ventilation. And
or also invasive ventilation.
Or invasive ventilation. And these children would also be considered as vulnerable children. So I'll go back. And what about sickle cell anemia?
The American Sickle Cell Foundation has come out with a clear statement saying that sickle cell disease is a risk factor for more important problems with COVID-19. Sickle cell trait is not. And in sickle cell disease, they included all the forms of sickle cell disease.
Okay, I'll probably need to explain this. As trait, you mean a sibling?
No, trait, you're a carrier.
Carrier, yeah. So for example, a brother or sister who has no disease. Okay, so
exactly.
And I just checked, I have approximately 6 or 7, no more actually, question about diabetes.
Okay, so diabetes, from the adult literature, diabetes is a risk factor for more severe disease.
But may I interrupt you here? Diabetes type 2 or?
This exactly is what I'm going to address right now.
Sorry, because
that is why I wanted to address diabetes in and of itself.
Okay.
You have to realize that the diabetes as a risk factor is typically type 2 diabetes in older adults who often have comorbidities, particularly obesity and hypertension, both who are also increased risk factors for more severe disease.
Okay.
At this point in time, it is unclear if children with type 1 diabetes have this increased risk or not. So there are subtle differences. We just don't know enough now. Matter of fact, I read a discussion this morning particularly about that. And a diabetes expert pointed out that that difference between type 1 and type 2. And we just don't have enough information right now about type 1 diabetes. You have to realize not many children have been hospitalized despite large outbreaks in Europe. So it's suggestive that children with diabetes, which is a common disease, type 1 diabetes, does not seem to increase risk. There hasn't been that signal yet, but I think the data is too scattered and not known to be more definitive on that.
So what we discussed is that immunosuppression seems to be a very clear indication for these children not to go to school. Immunosuppression, it is both innate immunity and T-cell based immunity. You also mentioned that by your estimate, only about 10% of children with asthma, you would consider them at risk for COVID-19, about 10%. And we discussed the criteria, they're listed here. Cystic fibrosis, bronchopulmonary dysplasia, and primary ciliary dyskinesia. These three diseases, you gave recommendations based on age, less than 2 years or above 2 years, and whether or not they can do pulmonary function tests. And an important criterion was prior viral-induced disease, prior exacerbation, worsening of the disease due to viruses. And I will just emphasize, you meant not just COVID-19, you meant something like common cold.
Yes.
Cold-induced asthma, for example. About the line, children in need for oxygen or ventilatory support, I'll just switch to the other slide. You mentioned that these are children could be at this condition because of genetic disease or because of malformation, and ventilation can be invasive or non-invasive. About sickle cell anemia, you mentioned that there was a statement from the American Association on Sickle Cell that stated that someone who has active disease is at risk. Someone who is a carrier is not. Diabetes, you mentioned that we only have data from diabetes type 2, and I completely agree with you, because older individuals with diabetes, they may also have the immune system changed or modified because of diabetes. We don't have enough information about diabetes type 1 diabetes. If Igarim is okay with, did you get all this information as summaries? Okay, perfect. So we can move on, elaborate a little bit on asthmatics. And I think it's important to emphasize viral-induced asthma. It's not about COVID, but viral-induced asthma from the history, from the past history, such as from common cold-induced asthma.
Yeah, so we decided that those children who were at risk were vulnerable asthmatics. One, as evidenced by frequent trips to the emergency room. If they needed to actually go to the intensive care unit for their asthma in the last 2 years, we thought that they were vulnerable. If they're on high dose of inhaled corticosteroids, and I believe we have a slide coming up to discuss that.
Yes, we have a slide, yes.
Yeah. If they're using biologics, such as Xolair, and the occasion there are patients who are on regular systemic oral corticosteroids, they would also be considered a high-risk asthma group.
I will now switch to the slide in a different language so that Igarim will be able to finish off her translation. Okay. And this is the table that you mentioned.
Yeah, so I won't go through the details, but different molecules have different thresholds for what is considered high dose, and that is listed here. I've listed these using the trade names that we use in Canada, not as an endorsement, same thing for Xolair, but we were developing this as patient information, and we wanted to use terms that our patients would understand.
Okay.
For children under the age of 6, those thresholds are half the thresholds that we have for those over the age of 6.